I indeed will speak a little bit about the work that I've been doing over the last 20 years on the experience sampling method and how we can move from macro to micro environment. And I actually think my talk is going to be nicely complementary to what Michael Green has been talking about before. So what we've been doing is measure people in their normal daily life, and in a way, this is sort of moving us towards a science of behavior. And I want to speak a little bit to start with about a talk that you've heard 2 days ago by Thomas Insel, who was speaking about the use of technology to understand better what is happening to people. So he was talking about digital phenotyping, where you use the phone and everything that people do with their mobile phone to sort of predict when people will become ill. Now the question is whether this is enough and whether we don't need to do something additional. Because one thing that I feel is missing in digital phenotyping is the experience of the person and the experience as it occurs in the context. And I would call that the interactive phenotype. So do we also have to capture the interactive phenotype and how people behave, react, experience things in their normal daily environment? In a way, I think digital technology, if we just use it to build algorithms to predict, for example, when someone will become depressed, I think we miss an opportunity. And that opportunity is to make the patient a more active participant in his or her own treatment process. If we can use digital technology to actually make people aware of their own patterns of behavior, that may be more helpful to move forward towards, for example, a personalized approach in psychiatry. So what could that look like? And is it really feasible to add something additional to all the digital technology that we use? So that is what I will talk about today, and what I have been doing over the last more than 20 years is using the experience sampling methods. What is that? That is a method where we ask people to, in a very structured way, to give a self-assessment in the context of their normal daily life. We used to do that just with a diary and a watch. And the watch would emit a signal 10 times a day at random moments, and people will fill out questionnaires about that current moment. Of course, this has become much more easier. Now it's just an app on a phone, but basically we're doing exactly the same thing. So we ask people to fill out a questionnaire on that specific moment. That is about, for example, moods. How do you feel at this moment? Do you feel anxious, down, lonely? Do you feel relaxed, content? Also on symptoms. Do you hear voices? Do you feel suspicious? Do you feel that other people are influencing you? But also in the context. Where are you? What are you doing? Whom are you with? And how do you experience that context? Do you like the people you're with? Would you prefer to be alone? Do you like the activity that you're doing? And so that gives us a very, very rich picture. And so to speak, rather than just taking a snapshot, we're sort of making a film of how people are doing in their normal daily life. And I will now talk about how we can use this approach to get a better insight in what's happening in people, but also maybe to get to better treatment. So first of all, it can help us to improve our understanding of symptoms as they occur in real life. First of all, what we see is that there is a lot of moment-to-moment variability, not just in mood, but also in symptoms related to schizophrenia. So, for example, these are data of 2 different persons, and we see that people, that this lady, this is on Monday, several beeps per day, a score on 1 to 7, And there are peaks in paranoia, but also moments when this person is actually quite okay, compared to this person who is much more variable and has quite a few high peaks. But also hallucinations seem to vary a lot from moment to moment. Again, several beeps, and we see variations both in visual and auditory hallucinations. And this holds again for these participants. So if we just speak to our patients and we use a retrospective approach, it's very difficult to capture that variability. But this variability is actually quite interesting because it can help us in understanding what is driving that variability. Why are there moments when the peaks are so high, and why are there moments that the peaks are that there's actually none of these symptoms present? But it can also help us understand better negative symptoms. It's not just about the positive symptoms. For example, let's talk about anhedonia. So we ask people to rate their positive affect in the context of their normal daily life. We did that in a group with at-risk mental state, first episode of psychosis, and healthy volunteers. And what you see in the two patient groups is indeed that they score lower positive affect in the flow of their normal daily life, which could signal that they indeed have less capacity to enjoy or less hedonic capacity. However, the question is this really true? Or is this maybe a reflection of a life that is not so pleasant? Do they have equal amount of reason to feel good? So what's interesting with experience sampling is that you can then investigate that question. So what we do is we ask people also, one of the questions is, when you look back from the previous beep to the current beep, what was the most important thing that happened? Of course, we ask that 10 times a day. So it's usually not, I got married, I found a job, I got a divorce, and I had a car accident. It is small things that happen in the flow of daily life. One of the beautiful events of me this morning was to step outside on the terrace and have a beautiful view on sunny Naples. So it's small things, but what we then can do is we can look at the moments when people report something pleasant, a little bit pleasant, more pleasant, and we can see how people react to that. So we can look at the association between their positive affect and positive events. So this is what we found when we look at that association. We see that, and it's a bit hard to see, but I'll explain. So this is the healthy volunteers, patients with first episode of psychosis, and patients with an at-risk mental state. And we basically hardly see any difference between these groups. So when something pleasant happens, all these groups have an increase in positive affect. They enjoy the positive things in life. Only there are fewer of these moments in people who suffer from psychosis. So, with experience sampling methods, we can understand the phenomenology a little bit better. We can disentangle what it is that's really happening in the context of real life. But we then can also capture the interactive phenotype. So how do people indeed react to the environment? I already talked a little bit about those positive events, but what about negative events? When people experience stressful things in daily life, how do they respond to that? And already many, many years ago, I published a paper showing that people with psychosis have a tendency to react stronger to stress, not just in terms of increase of negative affect, so they have a larger increase in negative affect, but also they have an increase in psychotic experiences, the intensity of the psychotic experiences. Interestingly, that was also true for relatives who did not have a psychotic disorder, but who had an increase in these more subtle psychotic-like experiences when they experience more stress in daily life. Now, recently, one of my postdocs is looking at that in a bit more detail. And what is nice with experience sampling is that you have multiple measurements over a day, so you can not just look at the initial reaction, but you can also investigate how does that roll out and what happens over time. So basically, this is the first moment of the day when there is stress. And then you see, these are the healthy volunteers, so their negative affect goes up a little bit, they have a peak. The peak is higher in a chronic group of patients with psychosis, and this is a group with early psychosis, including both at-risk mental state and first episode of psychosis. And you see that this group, in the early stages of psychosis, are most sensitive to that environment. They indeed react most strongly. They have the largest peak. But what was very interesting is that we then investigate what happens to the next moments. In a way, you can call this recovery. How quickly do people recover from that stressful event? So what you see in the controls, in the healthy volunteers, is that they very quickly, they have a slight bump, something negative happens, your negative affect increases a little bit, and you very quickly go back to your normal pattern. In a way, that's also true for the people with chronic psychotic disorder. So they have a peak, but they quite quickly go back to baseline. But what we see in these early stages of psychosis is that people have a much larger peak, and it takes them much longer to return to baseline. So not only they react stronger, but also it takes much longer to recover from that. So you see that it takes about 3 beeps later to recover, and a beep happens in a time frame of 90 minutes. So it's actually a matter of a few hours before people go back and recover from. So you can imagine if you just live your normal life, you have constantly these small stressors happening, and if you tend to react strong, and then it takes you a long time to recover, that has a major impact. This is also true for recovery in symptoms, and that's true for this group as well, mainly. So you see an increase in symptoms, and then it takes them 2 beeps to recover from that. So we see that it helps us in understanding how people react to the world, how the world has an impact, the context has an impact on the intensity of these symptoms. But we can also use this method to examine the social world. What is happening in the social world while it is happening in real life? And it sort of allows us to look at 2 different things. One is sort of what we call objective measurements. So that is mainly how much time do people really spend with other people? How much time are they alone? But also then next to that, we can look at what we call the social experiences. How do people feel when they are together with others? For example, how do they feel judged? Do they feel safe? Do they like the company they're with? But also their intentions. I would rather be with others when alone, or I would rather be alone when with others. What we've seen is we looked at, for example, the social functioning scale, widely used scale to measure social functioning. And what we noticed when we compared the social functioning scale with experience sampling data is that it's quite good in capturing that objective social measures, but not really in capturing that social experiences. And maybe both are relevant. So we have a very large data set of people with psychosis, people at risk for psychosis, people with depression, based on the studies that we have conducted over all these years. And so basically what we see is that compared to healthy controls, so this is now the actual time people spend in these conditions. So we see that people with mental health conditions, those 3 groups, all spend much more time on their own, 40 to 50% of their time, compared to lower than 30% in the healthy volunteers. That people with depression spent more time with family and friends, and that basically that is people with the psychosis risk, for example, they're more time on their own, but when they're with others, they're more often with people they don't know that well. I think it's important to look at these things because it can help us quite a lot in understanding what's happening to people, but also how much what treatment is doing and whether treatment is affecting these things. So we investigated a group of non-remitted patients with psychosis, remitted and controls, and this was remitted based on the PANSS, so they were remitted based on symptoms. So what we saw was that the healthy volunteers, again, spent less time alone, but that both groups, remitted and non-remitted, spent equal amounts of time alone. They spent equal amount of time doing nothing, and they equally spent less time in goal-directed activities compared to the healthy volunteers, suggesting that when we say someone is remitted, we're not done, and we didn't do enough. These people are remitted in terms of symptoms, but haven't been remitted in terms of participation, social interactions, and so on. We just recently finished the first wave of a large cohort study that we set up in Flanders in almost 2,000 adolescents aged 12 to 16. And also in that sample, we looked at these. First of all, just the results on the actual complaints. So this is also a community sample, a general population. And we noticed that almost 50% of these young people had mild psychological complaints, and almost 17% of the group had moderate to severe mental health problems. We then looked again at the social situation, and so what we noticed indeed is that we also made 4 quadrants. So in those with fewer problems and those with more problems. And so what you can see very nicely is that the more mental health problems you have, so the higher you are, the more time you actually spend on your own, even when you're 12, 14, or 16 years old. So it already starts quite early. But what was very interesting was not just to look at the actual time spent with others, but also at these social experiences. And so what we saw was that the people with most mental health problems from this general population adolescent sample, that they... this is an intelligence test. I keep pushing the wrong button. So what you notice is that people with more psychopathology in this general population sample say that they feel the company they're with is less pleasant. They feel less safe when they're with others. They have a higher preference of being alone. So they say, yes, I want to be alone when they're with others. They feel more judged, and they have less a feeling of belonging. So already at these early stages, when mental health problems start to occur, you see an association with the social environment, and both on the objective level in amounts of time people spend with others, but also in the way the environment is experienced. One of the interesting data of this sample, which I didn't put in the slides, is also that we see that people who are more who have better social skills, have more social competence, actually also present lower mental health problems. Of course, also there we can't speak about directionality, but it was an interesting association. All right, so experience sampling is helpful. It can teach us something about the actual symptoms. It can say something on variability of these. It can teach us something about how the interaction with the environment works, the interactive phenotype. But can we use this in practice? Is there a possibility to translate this to clinical practice, and how could that work? So, for example, I already said, well, we see that there is variability. So what would be very interesting, for example, is if we could start predicting, for example, okay, so this is a moment, this is paranoia, this is one day. You see at one point paranoia goes up and then it stays up for a while. So can we predict what is happening here? So why is the paranoia going up and why is it staying high? If we could predict that, then of course we could identify targets for treatment. We could maybe target the things that happen there. So we looked at it and we found, for example, that an increase in anxiety and a decrease in self-esteem is predicting an increase in paranoia. So you could say from a clinical point of view, maybe if we want to target paranoia, we need to work on self-esteem or anxiety. However, can we really translate that to the individual? So if you look at these data, I've already shown them earlier, so this is the paranoia. For this lady, you actually see that indeed, for anxiety, this is sort of going in that way. More anxiety, more paranoia, low anxiety, low paranoia. Also for self-esteem, which of course is going in the opposite direction, you see that it's working. So low self-esteem, high paranoia, low self-esteem, high paranoia, high self-esteem, low paranoia. So this lady would say, if you say to her, we know from the literature that anxiety predicts paranoia, this lady would say, yes, that's true. That's how I feel it. However, for this person, for example, it doesn't seem so aligned. For example, low anxiety, high paranoia. Low anxiety, high paranoia. High self-esteem, but also high anxiety and high paranoia. The second person would say, it doesn't really work for me like that. And then we would write down in our file, low insights. But this is not really true. For this person, this is how it goes. So what we did, the study where we found a group finding on anxiety, self-esteem, and paranoia, we looked at each individual patient. And that's the nice thing with experience sampling data. You have a lot of data from one person, so you can look at associations within persons. So what we found was that only for a few people, anxiety predicted paranoia. For other people, it was the opposite way around. First they became paranoid, then they became anxious. For some people, paranoia actually reduced the anxiety. For a number of people, only for 30% of these individuals, we could find an association. In 30%, there was no association, and in 30%, one of the variables had no variability, so we could not look at an association. A similar thing for the association between feeling tense or relaxed and paranoia. So some people become paranoid when they're more tense, but other people become paranoid when they're more relaxed. For some people, when they're paranoid, the tension goes up. But for some people, it actually lowers the tension. So you can see that for each of these people, you would need to do something different. And this is really how what we can do with experience sampling. We can look at individual patterns. We're not talking about psychoeducation based on group findings. We can actually work on psychoeducation based on your own data. What are your patterns of risk? When is it? What is happening for you? And so I think that is a really important strategy to improve our understanding or to improve the way we treat our patients. If we can start working on an individualized approach where people actually collect their own data. I think this is actually really also helping in shared decision making. If you give people a tool to bring their own experiences to the table, then you're working on a more active relationship between the clinician and the patient. And the patients can use this to really demonstrate what are their complaints and symptoms in the flow of normal daily life. So the next question then is, okay, so this is clinically relevant. We can use it. We can also use it to evaluate treatments better because we have more fine-grained data. We have more detailed data on not just the symptoms, but also what people do, how active they are, their quality of life. But then the next step is also, can we use digital technology to improve our understanding or to bring the therapy from the doctor's office to the real world? And then we start talking about ecological momentary interventions. So can we also treat people in the flow of their normal daily life? So what is that, an ecological momentary intervention? So basically, we try to use digital technology to deliver therapy in the real world at moments when it's most needed. And basically, you provide a sort of round-the-clock support. But more importantly, I think it may induce sustainable change, which I will explain in a minute. So I will now discuss two potential ecological momentary interventions. So one is behavioral activation in real life. This was in people with depression, chronic depression, and they were basically randomized in 3 groups. So there was one group, the control group. They got just treatment as usual. One group did experience sampling, but they didn't receive any feedback, so we call that a pseudo-intervention. And then one group, they did experience sampling, and they did receive feedback. So, as I said, this is in people with depression. All these people were chronically depressed, had been on antidepressants for a long time, all had residual depressive symptoms. So basically, what was the feedback that we were giving people? We basically gave them feedback on, for example, the sorts of activities they were doing and how they feel in that sort of activities, particularly focusing on positive affect. So here we have a graph of the amount of time they spent in different activities. And here you can see the positive affect they have in that activity. So for this particular person, active relaxation or active leisure activity results in most positive affect. But when you look here, this is the dark blue, you can see that this person spends only very, very little amount of time in that situation. And this was basically the only thing with it. We gave feedback on this is how you feel in these situations, and this is the amount of time you spent in these situations. We did that with relation to the social environment, the sort of activities people were in. And these are the data. So let's first look at the control group. You can see that this is pre-measurement, post-measurement, and then for a 24 weeks after treatment, nothing happened in the control group. We call that group neglected as usual. Then we have the intervention group who got the pseudo-intervention. So these are the people who filled out experience sampling. But then, and so just to be clear, I just realized I didn't explain that very well. So people did experience sampling for 3 days. Then they came back, they got a feedback. The next week, they did it again, the next week, and they did it like that for 6 weeks. So filling out experience sampling for these 6 weeks clearly was helpful while people were doing it. However, it didn't last. So 24 weeks after treatment, their symptoms recurred. They went back to their previous level of depression. However, the people that got the intervention, what you can see and what is very interesting is that they started to improve, and that they improved even further after 8, 12, 24 weeks. And this is what we usually don't see in an intervention study. Usually you see the highest effect immediately after the intervention, and then it sort of becomes a bit less. But here, clearly, by making people aware and giving people insights in their patterns, something changed, and people started to do something different. and that different pattern of behaviors resulted in less symptoms over time. What we saw was that people became more active, that they also were more in contact, spent less time doing nothing. And so this is a very interesting finding to see that by using something like that, you can give people tools to really work on their own problems. We are currently running a trial on, which is called Interact, and that is a trial on acceptance and commitment therapy in daily life. So what we do here is, again, we have a randomized clinical trial where we look at treatments as usual and cognitive behavioral therapy, and we compare that to acceptance and commitment therapy in people at the early phases of psychosis. So this is at-risk mental state and first episode of psychosis. And what we do here, this is a multi-center study in Flanders and the Netherlands. And what we do here is basically people have sessions with their therapists. So they have a session on ACT, one of the ACT sessions, which can be about acceptance, diffusion, etc. But each time they see their therapist. When they go home, they get an app. And in the app, they do experience sampling. So a few times a day, they rate themselves, which is in and of itself sort of a mindfulness exercise. You think about your current feelings in this moment, but then they also get a short exercise. And so the idea is basically that it's very difficult to translate what you learn in therapy to your normal daily life. But now we ask people to just practice with the normal things that happen in daily life. And we hope that when they practice a lot with the normal small things, that they can also apply these techniques at moments when it's more needed. So we managed to, in the end, have 150 people in our trial. However, we are still conducting the follow-up measures, and therefore we cannot really look at the data yet. So we just have some data on feasibility right now, where people say, well, they found the app useful, they said the app helped with applying the exercises, and the app definitely helped in becoming more aware of how they feel. But they also said the number of beeps per day were burdensome and the duration of beeps were burdensome. We also added a qualitative study to that, and I just have some quotes from that. So some people said, this is the first thing that really helped me. I very strongly believe my thoughts. That has come down. The app is helpful because it brings you constantly back. Remember your exercises, your breathing. What do I feel? And the app created awareness about what I was doing and what I felt. But they also said, I did not like the beep. It irritated me. The questionnaire was very long. That was annoying. The same question came back over and over again. So the development of this Interact and the Act in Daily Life has been part of an ERC grant, and we now got money for implementation. So what we're basically currently are doing is collect all that information to improve the app, so that it's really becoming a clinically useful instrument. One of the things we do is now it was a hierarchical, so you had to first do session 1, then 2, and so on. Now we're just going to make it modular, so whatever the therapist is using in his therapy, that they can use the module in their normal daily life. We're probably going to reduce the questionnaire a little bit so that people can really use it. So I was really quick, so that's nice. Then we have lots of time for discussion. Just as a roundup of my talk, so what I think is very important is bring the personal experience back into the picture. So what for me would be an optimal strategy, because people of course cannot follow themselves or do self-assessments for days and days and days and days and months and years in a row. So I think what would be a very good strategy is to use something like your phone, sensors, wearables that people can wear for a very long time, not to signal you're becoming depressed, but to signal something is changing in your pattern of behavior. And that would be an excellent point for triggering an experience sampling period so it would basically signal maybe it's good that you start some self-assessment to understand what is happening in your life so that you can actually do something about that. And I think that would be a very, very smart integration of all these different ideas. So bring the personal experience back into the picture. Capture the interactive phenotype. The environment and the context is enormously important and clearly influences the way people feel, the way people behave, etc. So it's important to understand what are for you risk environments, where do you feel well, what sort of activity fits you well, what sort of social context is good for you. And then this can help us to provide tools for people to help themselves in real life. As I said, I think it's important for self-management, for shared decision-making. It helps to empower patients and to give patients the tool to bring their experience to the table. At the same time, I'm not a big fan of EMIs replacing psychologists, psychiatrists, clinicians. I think the best result will come when it's an integration of both. You need the person the face-to-face interaction, but at the same time, with these tools, people can help themselves, can really, in a very structured way, practice and exercise in their normal daily life. And at the same time, when the symptoms come back, before they get an appointment with you, they may be already able to get some help that they need. And then I think it's really an opportunity now to translate this real-life data into clinical practice. That's not the easiest thing to do. There's lots of barriers, technical barriers, ethical barriers, data, privacy, and so on. But it's really a challenge that we need to take on, because I think this is really helping us in improving our science of behavior. But more than that, I think this is one of the real opportunities for this approach is to get some precision medicine in psychiatry. I think this is really a tool that can bring us to personalized medicine.